Hello, not very tall, so I'll put this down a bit. Hi, my name is Krishna Bhatti, and I'm from Coventry University in the UK. And my talk, when they got it up on the screen, is going to be about an intervention that I designed as part of my doctorate program in health psychology. It was actually a poster that I was going to present, so it's not going to be very clear. So what I'll do is I'll just talk you through the different sections. You'll lose it. Basically, this is an intervention that I developed for South Asian immigrants in the UK. As you may know, that South Asians have a 50 times more risk of developing lifestyle, behavioural kind of health problems like type 2 diabetes and coronary heart disease than the general population. And a lot of these sort of problems, health problems, are attributed to lifestyle behaviours like unhealthy diets and inactivity. Now, a big problem with the South Asian communities, especially immigrant communities in the UK, is that they kind of don't engage very well with mainstream services. So they don't tend to get the help that they need before their sort of health problems get worse. So what I try to do is, because it's the engagement problem that's one of the issues, what I try to do is to bring the services to the population in a context where they would be comfortable in. So what I did is I used a theoretical model called the COM-B, which is a very newly developed model in health psychology, which has three main components. COM stands for capabilities, opportunity, and motivation. So the opportunity was to provide them in a context, which seems to be quite a running theme in this conference, that contextual factors are really important when we're trying to promote behaviours in certain contexts and population groups. So the opportunity was to provide a context in which my population group would engage. And what I'd found is that the local Sikh temple was a place where this particular target group felt quite comfortable. So what I did was to try and get healthcare professionals to come into that context and deliver sort of health education and sort of skill-based activities within that setting. So what I did is I followed the COM-B model and designed an intervention to help promote those three main core components. One of them being motivation as well to change. So trying to change their kind of like attitudes towards the foods that they should eat and also activities that they could be capable of undertaking. I used a range of different sort of materials. Some worked and some didn't. But overall, just to briefly summarize, it was a 10-week intervention, and they did engage quite well in the intervention because one of the main things that was found is the communication between the healthcare professionals delivering the information they found really useful. Normally, communication regarding health is communicated by the GPs or healthcare professionals in a sort of healthcare context where they don't really check understanding, even though some participants may, people from our community may sort of occasionally nod their head and, sort of try and show the doctors that they've understood, but they don't really understand. And the reason why they'll just nod their heads when they walk out of these sort of healthcare settings is because they don't want to appear, stupid in front of these people that are sort of professional with professional labels and backgrounds. So they felt more comfortable listening to the information in that context, and were able to ask questions and clarify any issues they didn't understand. So just in a nutshell, the 10-week intervention, although it didn't show any kind of objective changes in sort of measures like weight or blood pressure or things like that that would help sort of show some kind of indicators in that physical health had been improved, but their attitudes had changed and their beliefs had changed as a result of the information that was that was provided. So it does show that these sort of community-based interventions can be quite useful in promoting behaviour change and imparting that very important knowledge about their behaviours and how that links to their ultimate sort of health outcomes. And that's it. Thank you very much. Very quick.
Thank you, Krishna. That was actually...
Thank you very much.
Hello, thank you very much. It's congratulations. I think it's very interesting that you have used not only an intervention, but it's a culturally sensitive intervention. And also, when you talk about culture, you've used the temple. So the temple has a social strata as well. So obviously, even from what you dress to what you talk, will be more culturally relevant.
That's right. Yeah.
So I think when we do interventions, why interventions fail, in my experience, is that we do not give the due respect to the culture. Now, it could be adolescent culture, it could be like a gang culture, or Asian immigrant Sikh culture that you're talking about. I can remember my friend in Bradford, and when you go to the temple, you know how effective that is. So I think even it's a 10-week intervention, I would like to know whether after your intervention, how does the NHS and the other stakeholders see the development of service utilization?
This kind of intervention has been done before, but it's never kind of like carried on. So I feel that because I'm situated in a university that has a very strong connections with public health services, that through that collaboration that we can make some noises within the mainstream services and show them some evidence, not just of this little pilot study that I've done, but other interventions similar to this that have been conducted within our kind of geographical location, to add some sort of weight into there is some utility in sort of developing these kind of interventions long term. Does that answer your question? Ish. Yeah.
Thank you, Krishna. I think that's another conversation that's going to go on and on over coffee, dinner, coffee again. So thank you very much.
Thank you, everybody.